sure there's no other snafu.
Thank you, Jamie.
Okay.
All right, there we go. I see lots of people joining in. All right.
All right, I am here.
Hey, Andy. Lots of people are joining. Hey, those of you that are joining, go ahead and say hello in the chat. Let us know where you're coming in from. We're getting a little bit of a late start, but it's going to be so worth it. All right, I see people joining from Oklahoma. I know we have some people from Portugal. Hi, everyone. Some of us are located here in Ohio. Dr. Marks is joining us from Chicago, Tennessee, Michigan. All right, I think we'll go ahead and get started. We have a little bit of an introduction here before we get to the meat of the presentation. So keep joining in the chat. Let us know where you're coming in from. If you have any technical issues, let us know, and Andy here will help you out with those. But we're going to go ahead and get started. So hello and welcome to our webinar, A Little Goes a Long Way, the latest in vaccine technology, sponsored by Merck and Covetrus. I'm Amy Bucher. I'm going to be your host today. So please, again, introduce yourself in the chat. Let us know where you're joining us from. Today is July 15th, 2021, and our live webinar participants will earn 1 continuing education credit. Now, if you're watching a recording of this webinar, you are not eligible to receive any CE for it. Sorry, but it's great information, so continue watching. As we normally do, we'll have a question and answer session at the end of today's presentation. So use the Q&A in your Zoom options at any time during the presentation, and our presenter will answer your questions at the end of the session today. So, and I'm excited to introduce today's presenter, Dr. Natalie Marks. She obtained her bachelor's degree with high honors in animal science from the University of Illinois in 1998, and then proceeded to obtain a master's in veterinary medicine and a doctorate of veterinary medicine degree with high honors from the University of Illinois College of Veterinary Medicine. She became a certified veterinary journalist in 2018. She has been a veterinarian at Bloom Animal Hospital since 2006, co-owner until 2018, and current medical director. Prior to 2006, Dr. Marks worked at a small animal practice just north of Atlanta, Georgia. Her media experience began in print when she created several monthly veterinary columns in multiple community magazines and was a frequent guest speaker for the German Shepherd and Bernese Mountain Dog Clubs of Atlanta. Upon her return to Chicago, Dr. Marks became very active in the Chicago Veterinary Medical Association, serving on the executive board. She was also a past board member of the Illinois State Veterinary Medical Association and an active volunteer to the American Veterinary Medical Association and American Animal Hospital Association. Dr. Marks received the prestigious Dr. Irwin Small First Decade Award, presented to a veterinarian that has contributed to the most to organized veterinary medicine in his or her first decade of practice. In 2012, Dr. Marks was awarded PetPlan's nationally recognized Veterinarian of the Year. In 2015, she was awarded America's Favorite Veterinarian by the American Veterinary Medical Foundation. And most recently, in 2017, she was awarded Novavax Veterinarian of the Year for her work on canine influenza. Dr. Marks, we are ready for your presentation.
Thanks so much, Amy. Hi to everybody. Sorry for that long intro. Next time we'll just say I'm a practicing veterinarian here in Chicago. I'm a mom of three young ones who have done some of my backdrop for today. So to all of you, if you're any of you parents out there, I congratulate you for surviving the pandemic as a veterinarian and a parent. And I'm also really, really interested in making very practical presentations for colleagues around the country and the world for lots of different things, including one of my passions, which is educating about infectious disease. So today, what we're going to learn about together, and I want to make sure, again, that this is practical, but also as interactive as possible. So feel free to throw things in the Q&A, throw things in the chat. We'll have hopefully plenty of time at the end for us to discuss a little bit more in depth about what it means to talk about vaccines, essentially to the new pet parent of today. And we'll talk about more specifics about them as we go. But before we go any further, again, just a quick disclaimer, this presentation is sponsored by Merck Animal Health, and we thank them for their continued support of our industry and of our education and for the health of humans and animals around the world. So thank you again, Merck Animal Health. So I get this a lot. I get this question, do we really still need to talk about vaccines? You would think, especially through the pandemic, do we still need to be really educating our pet parents about vaccines? And the answer is yes. So if you look at this relatively recent graph, looking at the total zoonotic diseases around the world, you can see that it exists on every continent and some more than others. And look at the US, there's over 90 zoonotic diseases. At this point, there's obviously the potential for more that we need to be aware of and talking about, not necessarily 90 in our first pet parent visit with them, but there are a lot that are very important in that first puppy visit, that first kitten visit, so that we are keeping our pets and our human families healthy. The World Health Organization, even in 2019, made this pretty bold statement that vaccine hesitancy, or the reluctance or refusal to vaccinate despite the availability of vaccines, is one of the top 10 threats to global health. And I think we're seeing that even now, right, in the pandemic, and certainly now that there's a Delta variant with the COVID strains, and we're seeing that there looks to be some segmentation in vaccinated communities and non-vaccinated communities and what's happening in those. So it is something that, yes, we still need to talk about. And I want to just give a very brief introduction. Oh my gosh, look at that horrible animation there that didn't work. I wanted to give a brief introduction though, and potentially just a refresher into really what it means to have an immune population, because that's really what we're going for when we're talking to our pet parents who are going to dog parks and community events, and just thinking about, in specific with canines, just keeping community health, or what we call herd immunity, right, in the companion animal world. Let's take a quick look, because you might be hearing some of these terms. And if you're like me, where I had, let's see, virology 23 years ago, it might be just a glimmer of what you remembered for a test. But I think it's really important to understand very quickly here. When we're talking about immune populations versus susceptible populations, we have to think about what's called R naught. That's at R is very small, 0. And that's basically a number that's an average of how susceptible a population is. So on average, when we're talking about, if you look at the top, those open circles, if you have one infected patient on average, and this is regarding human medicine, they think that that is on average transmitting to 4 new individuals, which you can see then transmit to 4 new individuals. And so essentially one infected individual can go to 20 new infections. That's what R naught of 4 means. So every virus has a different R naught value. Measles has 1, smallpox had 1, rabies has 1. They all have a different R naught. And when you're thinking about, especially when you're listening to human doctors talk about COVID, for example, the R naught percentage is basically what is telling us our target for mass vaccination. And that's what everyone's been talking about. If we got to hit this number for COVID vaccinated individuals in the US or in the world, that's specifically the number that they feel would, of course, make a susceptible population, 75% of the population immune. And that's the graphic at the bottom, where you see the open circles, again, the infected individual or susceptible individual. And then the closed orange circles, those are the immune individuals. And that's, again, the power of vaccination. Sadly, we don't have specific R naughts for canine viruses, but certainly we would love it if we did, because that would really help guide how many dogs in a certain population we would need to have vaccinated or immune to essentially stop the spread. That's really what we're looking at here. So when a new virus comes into the population, and I'm going to use here as an example, when canine influenza dropped in our doorstep in Chicago in 2015, we had a completely naive population. Again, that's represented by those open circles at the top. We had one dog that was carrying canine flu, came in here, naive population. If that R naught was 4, remember, so that's one infected individual can transmit to an average of 4. You can see this on the bottom, that sort of bell curve where the cases start and they spread like wildfire. And as the population gains immunity, either naturally through vaccine, the cases start to drop down. Well, when we have an immune population, and this is really where we come in, and again, we don't know the specific R naughts of our viruses, but we certainly are trying to gain herd and community immunity for flu or for lepto or some of the other vaccines we talk about and recommend. If we can create a population that already 75% of those patients are immune, you see there at the bottom, then when one infected or susceptible individual comes into a population, instead of spreading to an average of 4, they might spread to 1. And that's where we get that beautiful flat line where there's going to be potentially some cases, but they're not going to have that exponential or bell curve look to them. We're going to keep the populations that are sick very small numbers and hopefully not only help them have minimal effects, but also minimal transmission to the rest of the population. So I want to talk about two infectious diseases specifically when we talk about vaccination. One, because I'm obsessed, essentially, but 2, because it's considered right now the most common infectious zoonotic disease worldwide, and that's lepto. And I'm going to start this section by saying this: if you are not seeing it, it is seeing you. Now, I live in Chicago downtown. Yes, it is a hotspot for lepto. And so a lot of people around the country who know I lecture about this a lot say, well, yeah, obviously, Dr. Marks, you live in the rattiest city in the US. Everybody's crowded. They're at dog parks. You're going to have some lepto there. But I live blank and we don't have this and we don't have that. And I don't think I'm really seeing it. And I don't know if this necessarily applies to me. Well, this is what I want to show you. And this isn't even the most current numbers, which unfortunately we don't have a centralized surveillance agency for lepto yet, which would be lovely if we did. But from 2009 to 2016, if we look at the total number of canine lepto PCR cases around each state, you can see, yes, Illinois is certainly very heavy there, but look around the country. And if you're dialing in from one of your states, I know we had Michigan, I know we had Ohio, I know we had California, there is lepto everywhere. And the reason is because a few things. One is we aren't looking necessarily in the right places. 2, we're assuming some things that are what I would consider more lepto myths of the past. And 3, we as a population, including myself, we have not done a great job in educating new pet parents on why these vaccines are really strongly recommended. Now, you are looking at a Yorkie, yes. And yes, this is actually the poster child for lepto right now. This is the breed that we are seeing the most in hospital prevalence and positive cases of leptospirosis. When I saw this the first time, I was floored that a Yorkie was the #1 case, because when I was in school, I learned this was rural hunting dog disease, that these were dogs that were outside and going in creeks and streams and hiking and hunting. And those were the dogs that I had to screen. And they were coming in yellow and sick. It was pretty obvious. And that is not the case anymore. This is a disease that's urban, rural, suburban, prevalence highest in our dogs less than 15 pounds. So if you're not screening these dogs simply by breed discrimination, we need to think again, because again, the Yorkie is the poster child for lepto right now. I think the other thing is we were taught these classic signs of lepto, right? Fever, vomiting, diarrhea, and appetence, that this was kind of a GI presentation of sorts. But remember, there are a lot of other presentations that could ring true as lepto that we can't ignore. Uveitis is a big one. Inflammation of the anterior chamber of the eye. And if you think about it, leptospirosis is caused by a spirochete, a leptospire. We know another spirochete, sort of a cousin of sorts, right? In Borrelia, the causative agent of Lyme. Tick diseases are known for actually going into the eye and creating uveitis. Very similar biological behavior for leptospires too. So when you're seeing uveitis, again, don't ignore it. Remember, the eyes are the window to the body. We need to be thinking about tick disease, fungal too, but certainly also lepto. PUPD is a big one. Now, these are dogs that might act clinically normal to their family at home. But when we start quizzing them on what's actually happening with their water consumption and urination, we find that these dogs, as confirmed by basic lab work, are polyuric and polydipsic. And so lepto PCR testing is always on my top 5 list for a diagnostic workup for PUPD dogs. And I would hope that after this presentation today, you'll want to keep that too, because that's a great way to find what are considered these well symptomatic dogs. And then finally, abnormal bleeding. This is a little less common, but certainly one we need to think about when dogs come in with petechia or ecchymoses, or you're getting prolonged clotting times or lower platelets, greater than 50%. I think right now it's 58% of our dogs with leptospirosis present with thrombocytopenia. So keep that in mind. It's not just our GI dogs that are coming in. There are these other, what are considered now atypical, but probably will be more common presentations of this disease. So I'm going to get on my, it's probably more like a 45-second soapbox on why I feel lepto really should be more of a core vaccine versus what right now, by AHA guidelines, it's considered more of elective or non-core. These are just some of the common reservoir hosts for leptospirosis. We know that there are rodents of urban and suburban locations, but also farm animals like cows and pigs that can transmit different serovars. So I would hesitate to think that there's a dog out there that doesn't see one of these or has exposure to one of these at some point in their daily routine. Stagnant and slow moving water is also a risk factor for lepto. This includes sprinkler activity. So there was a huge outbreak in Maricopa County in Phoenix in 2018. And we found out through a lot of study by people much smarter than me that this was actually coming from the dew on the grass from sprinkler activity overnight. So we have to think about that in these arid parts of the country where we thought this is a rainy disease. It doesn't have to be. It's any kind of slow moving water. And as I said, urban, suburban, and rural populations. This disease can affect any age, any breed, any sex of dog. Very, very telling prevalence study that came out of Chicago, actually by the Ohio State University epidemiology team, looking at this exact finding and found a very large range in breed, sex, and definitely age, as young as 8 weeks of age. Remember, dogs can be carriers of this disease, which means they just shed this bacteria in their urine. They can act totally normal. So think about the unsuspecting family that has a puppy that doesn't want to house train, or a puppy that's having accidents, or a senior pet that's having accidents in the house. Not just in the house with the humans, but also out in the community at dog parks and daycares and other communal settings. And then finally, if that wasn't enough to try to sway you, in a recent study as well, 10% of leptospirosis positive humans acquired their infection from their pet. So 1 in 10, and that's on us, right? That's on us. So I think there's a lot of kind of swaying information, I hope, for you to take maybe a new look at your vaccine protocols and the way we're talking to pet parents about this disease. Real quick, I always get a lot of questions when I lecture about lepto testing. So a quick cheat sheet, because I think this is really important, feel free to screenshot. If you're doing a lepto test on a Yorkie and a PCR is positive, that is a slam dunk diagnosis. That patient has lepto. But if a PCR that you're testing is negative and it's a PUPD vomiting Yorkie who just ate a rat and lives downtown Chicago, and you're like, I swear this dog has lepto, I'd bet my life this dog has lepto, and it's negative, it either really doesn't have lepto and you need to look for that zebra, or it could be more often that you've tested too early and there's not enough DNA to turn up a positive test. So if that's the case, remember that there is another option for testing for lepto, and that's the MAT testing. The microscopic agglutination test. Quick review, remember that's antibody testing. The SNAP test that we run in-house, those are also antibody tests. And if that test is positive, first step we need to do before we interpret is think if that dog is recently vaccinated. If it has been, remember vaccines can interfere with antibody analysis. So we need to run that PCR. If they're not vaccinated, that's just like that PCR positive we just talked about. That is considered a positive test. But just like with the PCR, if your SNAP or MAT test, those antibody tests are negative, either it's not lepto, or remember, antibodies take time to form and to be able to be read, right, by labs. So if you've taken this test and it's too early, that's when we either need to retest or do again that test 2 to 4 weeks later to look for those convalescent antibodies and hopefully get a positive result. But when we talk about vaccines, remember, avoidance is not an effective strategy for lepto. We talked about all those risk factors from the reservoir hosts and the water and communal areas, and any age, breed, sex of dog is affected. Up to 8.2% of dogs are shedding lepto right now, some asymptomatically, right? They're just going to the dog park, peeing and shedding lepto to unsuspecting folks there. So this organism can also potentially persist in the kidney and shed in the urine for weeks to months. This isn't like toxo in cats where we get like this 3-day range and we can move on. This is a lingering urine shedding. So to do the best for our patients and to do the best for our families, remember, we've got that as public health officers, we've got 2 responsibilities here. It's incredibly important to discuss this potential risk and make sure that clients understand without vaccine, avoidance is almost impossible. So if you have any questions about lepto for me to expound upon further, feel free to throw it in the chat, the Q&A, I'm sorry. I could talk about lepto for hours, but I don't want to monopolize this. And we definitely don't want to forget about our respiratory diseases. We're going to focus on parainfluenza today, the virus that we just cannot ignore. And why parainfluenza when we have so many other diseases in the, what we call the CIRDC, the canine infectious respiratory disease complex. And that's because in several studies as of late, canine parainfluenza is the major pathogen of CIRDC. And if you look at this, looking at parainfluenza at the top at 29%, we've got some mycoplasma species, influenza A, Bordetella, corona, going all the way down to strep equi. You can see that the percentage there is over 25%. So 1 in 4, we have the potential for having parainfluenza play a part in that respiratory disease. The problem, again, sort of like lepto, right, is that the clinical signs are just nonspecific. These dogs are coughing or sneezing, having nasal or ocular discharge. They can have fever, lethargy. Less commonly, they can have pneumonia. Certainly, it's more of a mixed infection a lot of times when we see pneumonia. But it's nothing that just signals parainfluenza where we can, again, either have avoidance strategy or just do targeted vaccines. The other thing is transmission and incubation periods make it very tough to quote unquote avoid. Transmission is typically aerosolized, right? It's almost impossible to avoid aerosolized transmission of respiratory disease, but also fomites. Those could be fomites in a kennel situation, a daycare, or we could be the fomite, right? So transmitting between cases or patients that come into the hospital. Incubation period for parainfluenza, 3 to 10 days post-infection. And then there is viral shedding that occurs 6 to 8 days post-infection as well. So not only are those patients clinically ill, they're also shedding and transmitting to the environment. And remember, when we looked at our transmission of disease sort of diagrams at the beginning, we don't really know the R naught for parainfluenza, but we can kind of assume, especially if you're going into a very susceptible population, this could transmit very quickly into a whole daycare or whole kennel or whole dog park community. This is the only electron micrograph I'm going to show you, I promise. But I think it's very telling. If we look at the trachea of a dog on the left, your left-hand side, and you see these beautiful kind of hair-like cilia, right, that are sitting there, their job every single moment of the day is to flick bacteria, viruses, foreign particles up, sort of like a wheat field, right, waving everything up so that it doesn't go into the lungs. Very important job, very mechanical job. After a canine is infected with canine parainfluenza virus, 72 hours after infection, these are the same cilia. So if you're familiar with parvo, it's almost essentially the same thing. Instead of the crypts kind of blunting, the cilia, the trachea, blunt and become paralyzed essentially. So nothing is mechanically flicking all of those infectious agents up. We just have this tube. So it makes those patients much more susceptible to secondary infections and lower airway disease, which of course is one of the reasons some of these patients don't do well. And it can take, in some patients, up to 60 days for that cilia to regrow and become functional again. That's a long time for that patient to be compromised. So again, very important to understand what parainfluenza does to those cilia. And as I alluded to, there are very common co-infection combinations here. If you look at CPIV, again, that's canine parainfluenza virus, that larger pink ball towards the left-hand side, you can see that it's often paired with Mycoplasma cynos, Mycoplasma canis, both of those Mycoplasma species, or Bordetella bronchoseptica. And when we pair that virus with a bacteria, usually the virus comes in first, we get the blunting and the immune compromise, then the bacteria can come in and colonize. We end up a lot of times having more risk, again, of those Mycoplasma pneumonia infections, which can be pretty nasty, especially if we aren't identifying the cause in the earlier stages. Now, immunology, again, very important when we're talking about vaccines, but just a refresh of those really important immunoglobulins. And this is why, of course, we're talking about vaccine selection. Remember, IgA is for the nose and throat. I always remember it, A is the first part of the alphabet. We certainly are talking about the first part of the respiratory tract. And then IgG is more for the lungs. So IgA is that key protector of all those upper mucosal pathways. And it's really stimulated to be produced and be really protective as much as possible when we use intranasal vaccines, because we're going right at the location, right, of those nasal membranes. Whereas IgG comes along later. It's a key protector of the lower respiratory tract. That is really stimulated more by injectable vaccinations, not by the intranasal, okay? So important shift in paradigm to think about. So when you're looking at your respiratory selections at your practice and, you know, what do I want to use, especially when we're talking about Bordetella vaccines, where there are a lot of different options, you want to kind of look in three different categories, right? There's intranasal options, oral options, and injectable. You'll see that the intranasal option is the only one right now that has a combination of Bordetella, parainfluenza, and adenovirus 2. When we're looking at antibodies, remember intranasal and oral are going to stimulate the upper respiratory tract, IgA, whereas the injectable, like we just talked about, is going to go for lower airway protection, the IgG. And when we look at the duration from challenge data, you know, again, how long can we anticipate protection in the canine patient that we're giving this to? It's in these studies, a year for intranasal and oral. It's somewhat unknown still on injectable. You'll see, I think one of the positives of intranasal as well is the onset of immunity, 48 to 72 hours. We'll start to see that. Remember, that makes sense because we're stimulating a fast-acting immunoglobulin at the surface. Whereas if we're giving an injectable, it's approximately 42 days after the first dose, but you see that's a question mark. The studies are still out. This is really unknown as of yet on our orals. So I've covered a bit about lepto and parainfluenza and sort of why avoidance is really quite a poor strategy, right? When we're not only recommending to our current clients, but today's new pet parent. And I say this in the most positive way, that it is a brand new world, right? With the pandemic explosion of pets that we witnessed, and specifically I'm going to be talking about our canine pet owners today, it's really a different client than we're used to. Because millennials have drastically changed veterinary medicine, both from a team member perspective, but also more importantly from the client base. So we have now a client base, the number one demographic of pet owners, I might say, that is experiential. So what I mean by that is, I myself am not a millennial. So when I go to the dry cleaner, I want to just drop off my dry cleaning, get my tag, and move on to the next. Whereas a millennial may want to go in, have a conversation, understand some options, potentially have, you know, maybe a cup of coffee that was offered to them, have an experience around the event. And that's the journey that they are hoping for at our practices. They also have an ecosystem around them. Whereas the client, some of my senior clients that I have, I am the end all be all for all of their dog or cat questions. Whereas a millennial now may have a veterinarian and a dog walker and a daycare provider and a chiropractor for their pet and a chat room and a play date group and so on and so forth. So a groomer, they're going to have an ecosystem of advisors essentially that are guiding them on the healthcare of their pet. They do want more, and I would say, and frequent communication from what we would typically provide. This is typically through digital means. They are information seekers. They definitely want those resources and papers and statistics so they can make the most informed decision. And they have significant concern about their pet's emotional health, not just physically, but how are they feeling emotionally? How are they connecting with them and other pets in their house or in their community? Because pets are not just pets anymore. So in a very recent TD Ameritrade study, 67% of these pet owners called these pets fur babies. They're not pets. They are actually likening them to a furry equivalent of a human in their home. And 55% of these pet owners said that the pet is basically like a child to them. And 44% of them said that their pet acts like a child. So in other words, they're postponing marriage and having their own human children so that they can parent this pet, which in their minds, again, is a child. And this is the new fur baby. So this is an example of what the new millennial client may have, which is a closet bigger, a little bigger than mine, for all of the wardrobe of a pet, right? And so for some of us that are not used to this shift, this can be a bit overwhelming, or certainly put us into a mindset of, I like how I practice. I don't know if I necessarily want to change a lot of these things. What I think we need to understand is that these new pet parents are our clients. And if we are not thinking about ways that we can be authentic to ourselves, but obviously help them be the best pet parent to their family, then we may lose them to a practice that does do that. And the downside that we had to curbside with all of these new pet parents coming in is that these first-time pet parents didn't have the great experience of being able to sit down with us in exam room, right? They were experiencing curbside service. And so what we forget about that is that they were not able to see a vaccine given. In fact, many pet parents have never witnessed that, the first-time pet parents. They weren't able to see some of the strategies we did to encourage better emotional health if you weren't doing video exams. And unfortunately, when we start to give recommendations, only 48% of them took our heartworm preventative recommendation. Only 35% took a dental recommendation for a prophy, and only 19% of them took our recommendations for prescriptive diets. So we lost some of that education piece because of the logistics of COVID. Now, with most practices opening up at some type of level and allowing more face-to-face interaction, we still have time to regain some of that sort of place within these new pet parents' minds and also families, so that they rely on us for accurate medical information. Because this is what's still scary. So Time reported in 2019, before the pandemic, that in a recent report from out of England that surveyed 4,600 pet owners, 25% of them had not had their necessary vaccines. And within the animals, US vets, and this is what Time reported, that some US veterinarians are willing to administer vaccines in small aliquots or doses, a fifth of a vaccine weekly for 5 weeks. So this was in Time magazine. So we know that we have a lot of work to do, a lot of ground to make up when we're talking to people who, as a first-time pet parent, if I read this in Time magazine, I might think, wow, that's something I should ask my vet about, because that sounds better than getting everything at once, right? But that's where low volume vaccines and other strategies can help change that, misrepresentation, can help address and sort of help us meet in the middle between what we knew and what the pet parent thinks they want, and finding that compromise so that they're comfortable in our medical decisions and we are protecting the pet and the family. So there's a few things that are important, I think, on both sides, right? We want to find common ground when we talk about vaccines for both veterinarians and also the pet parent. One, and I would say always top priority and should be, is safety, right? Giving them data if they would like that. We have package inserts. We have certainly partners that we use that are willing to provide safety data all the time, and making sure that they understand that. It has to be efficacious, right? There's no point in giving a vaccine that has poor protection or very short duration of immunity. And then it's very important to today's, especially millennial pet parent, but I think equally important for veterinarians, that we're both transparent, that we say as much as that we can that is accurate. And if there's something that a pet parent has asked us that we're not clear on or don't have an answer to, that we're not afraid to say, you know, that's such a great question. I don't have that answer right now, but I'm absolutely willing to find it and get it to you as soon as possible. But here's the other thing that we can't forget about, and that's comfort. And when we have a puppy that comes in that looks like this, with a very, 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 very worried new pet parent who has never seen a vaccine or injection administered, and then all of a sudden they have to drop off that puppy for a curbside and they don't know what happened inside the exam room, you can imagine that the peace of mind that we can give them is what's going to build trust. What we don't want to happen is for that pet parent, if you're still doing curbside, to get their puppy back after a first round of puppy boosters, let's just say, and that puppy seems, you know, kind of tired and doesn't want to be touched, and then doesn't eat lunch, and then, you know, is whimpering later in the day. And no matter what you tried to tell them after the fact, that pet parent, because I've had this happen to me, that pet parent could start going down a very negative road, right? What happened to my puppy when the puppy was there? Did they give the vaccines the right way? Did they give too much? Oh my gosh, did my puppy get the wrong vaccines? What is this veterinarian doing? What is this team? Did they handle my puppy the wrong way? I don't even know if I'm going to go back there. And that's unfortunately the experience that some pet parents have perceived in a curbside exam, because, you know, a lot of people have said, is the pet parent not in the exam room a problem? And again, with curbside, we had no choice for a very long time. But now that the world is opening back up in different ways, most experts agree 70 to 93% of all communication is nonverbal. And we didn't have the opportunity for many of us to really be able to communicate nonverbally through body language and sort of that dance that we do back and forth when we're communicating with our clients or pet parents. And so it really was a detriment to us to not be able to show our pet parents what we were doing, but also react to their body language. If they're starting to close their arms, if they're starting to shrug their shoulders, if they're starting to grimace, starting to tense, when we're doing things, we didn't have the opportunity to stop, hear what they were concerned about, and address it in the moment. So what we need to have, and this is, I think, a very strong, potentially polarizing phrase, but I'm going to say it anyway, is vaccination empathy for these first-time pet parents. I can't even tally. I was trying to, for this lecture, I was trying to think, how many vaccines have I given? I'm going in my 21st year right now. How many vaccines have I given in my career? And there's no way I could even fathom how many times a day I've given, you know, multiple vaccines to patients, right? And it's after you've been a vet for so long, it's so rote memory for many of us, right? That we don't even think about the experience on the other side. But these brand new first-time pet parents who are incredibly emotionally connected to these pets because they got them through the pandemic and are concerned about their emotional health, they need to see a little bit of empathy from us, because they just don't know what to expect. And so even though it might take a teeny bit more time at the beginning, I promise you that it will be received very, very well by the pet parent, and it will help to build, not disrupt the trust. We first just need to listen to that pet parent and find out what concerns they have about vaccination, right? Are they concerned it'll be painful? Are they concerned it's too many at once? Are they concerned that their pet doesn't need all of these, that we're not tailoring their vaccination recommendations? Or do they not vaccinate for themselves and they're translating it to their pets? Or, as I've had an animal communicator that they talked to said that this vaccine that they're going to give today is going to cause their animal to die. I know that sounds extreme. It's happened. I should write a book on some of these quotes, but we need to listen. We may not agree, but we do need to actively listen and hear their concerns so that we can try to address them. It's important to acknowledge that they exist. Sometimes it helps a pet parent just to say them. They don't even need an answer. They just want to vent because they just don't know how to feel. It's right. This emotional connection. Try to put yourself in the client's shoes, right? It's a brand new pet parent. They've never had a child. They've never, really been exposed to any kind of vaccines themselves, or maybe when they were younger, but it's this fragile little puppy and they're so concerned that they don't want them getting shots, right? We just have to imagine their perspective and then give both verbal and those really important nonverbal cues of empathy and compassion. I mean, we're such an empathetic group of people. we just need to keep doing what we're doing, but really communicate that non-verbally too, right? So we can't stand and, just kind of monotone delivery. When I talk to clients, I always like to sit across the exam table from them if possible, as if I'm at a Starbucks having a cup of coffee with them. And I try to tell them, you are part of the medical team of your pet. A lot of people don't think that they are, but I say, I'm the eyes and ears and palpation hands of your pet in the exam room. And you are that person at home for me. And I'm really counting on you to observe and tell me when things are going wrong, tell me when things are off, help me with, of course, the compliance of medication. So we have to come together at the table and figure out the best medical care for your pet. I'm going to give you recommendations, but I want some discussion. And that really, I think, sets the tone for a very casual and conversational approach to the new pet parent of today. There was a clinical impressions program summary looking at these low volume vaccines, and 1,583 doses of Novavax Edge, the distemper lepto combo, were given to 1,515 dogs. And 68 of those dogs received 2 doses. They were all ages, all breeds, all weights, really trying to get a really good general perspective of, low volume vaccines. Are they looking at where we're talking about safe and efficacious, and certainly providing that comfort for what we know the pet parent of today wants? The overall vaccine general assessment by veterinarians ranged good to excellent, and 100% of the veterinarians that were responsible for administering these vaccines deemed the vaccines safety satisfactory. So everyone there felt satisfied that administering the Edge, the low volume version of this, was again a safe option. And looking at that with, of course, with safety, we're looking at reaction rates, only a 1%. And the most common reactions that were reported were swelling and pain at the injection site, vomiting, and lethargy. Very similar in comparison to other vaccine reaction rates. So in close, before we go to some questions, this is really where vaccine verbiage is what becomes very important, right? We've talked about today 2 very important vaccines that need to be the discussion of that first-time pet parent, that Leptospirosis and Parainfluenza, for obvious reasons, and certainly staying away from avoidance strategies. And we've talked about what that pet parent looks like, what's important to them, what's priority, and certainly the emotional health of their pet. I would actually argue the emotional health of the parent too. But this doesn't have to be you creating a new workflow or SOP or completely changing how you practice. I think it's just, again, in the nonverbal cues you're giving, really empathizing with the vaccine kind of conundrum of some pet parents of today, and potentially just shifting some of the language in how you talk about vaccines. This is just an example of one of the ways that I sometimes do. I empathize with your concerns about Emma feeling painful after her vaccinations, and that you just want to make sure that these vaccines are safe for her. I empathize. It acknowledges how they feel. It certainly tells them that I was listening, because those were the 2 concerns that this client might have said about this sweet little Shih Tzu puppy. And then, I have stated that up front so that the client understands I'm on the same page with them. And then I might say something like, I'm worried about that myself as a veterinarian. I have my own dog, and I want to make sure those vaccines are safe and efficacious for her too. Or something like, safety and comfort are really important to me and my team, and that's why today I'm recommending blank. So having things like this where they are transparent, they're clear, they empathize, and you address specifically the client concern will help to put you both in the same place at the same time, so that those clients feel, again, supported, but they're more likely to comply with your recommendations and understand that you're just a human too, and that we can have this sort of back and forth discussion, and that I heard what you were saying, and I want to make sure that we're both coming from the same page because we're on the same team. So that's really kind of, as I close today, it's sort of the crux of sort of a back way to approach this. We just really need to stop having what have been called the cookie cutter vaccine recommendations, sort of that blanket slate of every dog at this practice is going to have blank, or every large breed is going to have this many vaccines and every small breed is going to have this many vaccines. I know that most of us aren't doing that anymore. However, we hear pet parents still reporting that. So What we want to do is think about, again, their perception of what's going to happen, and talk to them that we want to minimize the risk for each individual pet, right? Understanding safety and understanding comfort. And as a veterinarian, you have the option of talking to them about spreading out the vaccines, where we don't necessarily have to do everything all at once. We certainly can put together a schedule of vaccines. It doesn't take very long, and it can be emailed to the client so they can put it in their calendars, but they also can sort of double check. Well, today I know Dr. Marks is going to do blank and blank and blank. And if I come in and I say, well, we're going to do this, and they can go, well, that's not what you emailed me, right? One, it keeps me honest of what we've discussed, but two, it allows them to feel more in control of what's happening with the care of their pet. And then always, of course, I strongly recommend using AHA vaccination guidelines as a framework, right? A framework for your practice and your client base and your patient base, but certainly keeping in mind that those are they're statically there, but they're dynamically changing based on task forces and certainly the changing climate of infectious disease. So I'm looking to see if potentially my lepto dream of having that be a core vaccine ever comes true. I certainly hope it does, but for now, again, certainly use those as a framework and then adapt as needed for your individual patient base. So I'm going to stop my presentation sharing this right now, and I welcome Amy back. If there's any questions or chat that I can help answer after that presentation, but thank you so much for your attention.
All right. So if you have questions, you can throw them into the chat or into the Q&A. We're flexible. We can make it work. We did get a few that came in not in the public channels. So first question, what are some other ways to provide comfort during the process of giving the injection?
Yeah, so a couple things. Remember that most importantly, we need to communicate to the client through nonverbal cues that we're really interested in making sure that patient is comfortable as possible. So things that you can do would be, of course, to have low stress handling in your exams, making sure that you're using warm towels and non-skid surfaces, and you're utilizing what is considered, what is called T-touch. So it's a technique where we're starting at a low stress point of the animal to make contact. We're never really taking our hand off of the patient so that they always know that we're there. But then going to the high stress points at the very end. So that would be if a cocker comes in with chronic ear infections. We don't want to start with an otoscopic exam. We end there. Certainly if a patient comes in limping, we go to that spot at the end. So keeping in mind the comfort of the pet and talking through that with the pet parent so that they're always aware that you're thinking about that first. Having high reward treats for them so they have a positive association of being with you. There's calming music that you can use. Pheromone therapy is wonderful. Lots of different techniques that rely on basically making the dog's senses very comforted. But also, again, I think our verbal and nonverbal cues are just as important.
Excellent. All right. One more question that we've had come through. Do you test every respiratory patient?
I get that question a lot because so many people will see this and say, well, I have 30 coughing dogs came in last week and not every client was going to allow me to do a respiratory PCR. And I get that. Not every client lets me do that too. However, I would say there's two guidelines to that. So, or say maybe three. If you have a household that has 5 dogs and all 5 are coughing, I would at least test one if you can, right? To sort of get a herd impression of that home, because we want to make sure that we're not missing a bacterial component that we need to treat with antibiotics, and or also think about the contagious nature in the community. I think the second dog that I would certainly test is the dog that is febrile and has any signs of lower airway disease. So signs of pneumonia, either clinically or on radiographs, that certainly would warrant testing for sure. And then the third would be if you have an outbreak. So when canine influenza landed in 2015 in Chicago in March, we went from having 1 or 2 respiratory cases a day to 17 to 20 very quickly in a span of 3 days. So with those cases, certainly we're overwhelmed and we know something big is happening in the community, and we're trying to get, I say that loosely, we're trying to get ahead of it because we really couldn't, right, with influenza. But certainly that warranted getting a sense of really what was happening in the community, so that in that case, we were trying to work on getting a vaccine.
All right. Well, thank you so much, Dr. Marks, for your presentation and your expertise today. Thank you to Merck and Covetrus for sponsoring today's webinar. To our participants, please pay attention. I'm about to tell you something very important about your CE certificate. There will not be an automatic survey pop up for you. There is a link in the chat. I need you to click that link and go to that form. I'm going to show you what it looks like right now. So when you click the link in the chat, you'll see here, there are 6 questions. You just click start, you fill it out. If you don't fill out this form, you will not get your CE certificate. Let me repeat that. If you don't click the link and fill out the form, you won't get a CE certificate. So please do that because we want to make sure you do get that credit. This was just such a fabulous webinar. Thank you so much, Dr. Marks. All of the rest of you, go click the link, because once we shut the webinar down, the link is no longer available. So click it right now. I'll keep talking for just a little bit to give you time to get there. If you can't figure out where the chat is, raise your hand, click one of the things down at the bottom, let me know. And remember, we do manually process the certificates. It's not an automatic thing. We'll gather all the data, we'll build out the certificates, we'll email them to you, but you have to go click that link right now. I'm going to assume everyone's done that, and I thank everyone for attending today. Have a great rest of your day, and we will see you later.